many medications. Welcome back.
Thank you.
And we have Dr. Leffler with us from UVM Health.
Health. Got
Just
it.
UVM Health, okay.
Thank you. So good afternoon, everyone. And I want to thank you for the opportunity to come back and provide an update on UVM Health. Since January, when I was here, we've been basically completely focused on fundamentals. We've been focused on doing work to try and reduce our costs, improve access to care, driving quality and safety improvements for our patients, and trying to be really transparent, open, and clear about our current financial situation and everything going on. And I've been speaking a lot all over the place. Annie's running me all over the state of Vermont.
Sorry.
Yes. We did have a town hall. We have quarterly town halls for UVM Health. We had one on Thursday where we shared a financial update. I'm going to give you similar information today, and I'm happy to answer any questions you have around that. So the big change for us from January when I was here is the revenue impacts that were just kicking in on January 1st for us are now in full effect, and we're starting to see the impact of that on UVM Health. So to remind people, on January 1st, 2026, we had a new contract with Blue Cross Blue Shield Vermont that on average reduced every single charge we have to Blue Cross 12% less than it was in 2025. Across the board, at least 12, most of them more than that. For CT scans, we decreased our charges to Blue Cross by 25%. For MRIs, we reduced our charges to Blue Cross by 25%. And for the top 25 labs that we do, labs that all of us get when we go see our doctor, really something like a complete metabolic panel, more than 25% reduction.
Wow. Congratulations.
Thank you.
Yeah. I have a follow-up. I have a follow-up question. Too high. I have a follow-up.
So Act 55 fully started on January 1st. And so the prices that we charge our insurers for outpatient infusion drugs also significantly decreased, a lot more than 25%. Good news is these charges are absolutely lowering costs for our patients. I saw someone from my town in Heinsberg in the hospital about maybe 3 weeks ago now, and he told me that he had an MRI in November, and he had to have a repeat MRI about halfway through January, and his copay came down by 25%,
Wow.
which is a lot of money. And it was making a big difference for him with his heating bills when I saw him. So he was grateful for that. So it is helping Vermonters. I'm not saying it's enough, but they are feeling some impact. But let's be honest, premiums and out-of-pocket costs are still really high. We haven't fixed all of our access challenges. I'll talk to you more about the work we're doing there because we're trying to do a lot. And the federal financials look very concerning as you try and look into the future. So what we've really realized after January and February of our financials and a pretty good look at March is that we have to do more around the expense side for UVM Health. I will remind people that before I saw you in January, we'd already done some work at the administrative level for UVM Health, and we brought down administrative expenses by more than $8 million by consolidation of positions. So, for example, I right now am president of the medical center, CEO for UVM, still carrying some operational responsibilities for the medical center. So I'm doing 3 or 4 jobs, and we've done that for some other people too. We've combined some of our leadership jobs to drive some expense out of the system and have less of our highest leaders. The next phase of that work that we're starting to really focus on now is how to integrate some of what we call our shared services. So how do we make sure that we have the exact right number of HR people across the whole system, no duplication? How do we make sure that finance for like rev cycle and bills, we're getting those exactly down to the exact number of people we need, no duplication. Same thing for IT services. By reducing duplication, driving efficiency, and clear decision-making, there is opportunity there that we're starting to really work for now. I will comment that Mike Smith and the liaison team has been focused on productivity, specifically around provider productivity. To remind people, in our settlement agreement last year, there was some dollars put aside for some consulting work, and using a firm called A&M, they came and looked at productivity for our providers, our doctors, our 1,200 doctors, and they've found opportunities there for us to be more efficient, to improve access for patient care. And the work that we're doing there is really about optimizing schedules. So making sure that people It's a little tricky with patients, but everyone gets the schedule filled for the day, schedule filled for the week. No gaps, tighten those up. So if there's a cancellation in there that we find out today, we have a mechanism to put another patient who's waiting, have the schedules be filled. And we're opening up something called patient self-scheduling through Epic. So if you have MyChart, there's opening, it works for you, you can sign yourself up for it. We're really trying to make sure that we have the fewest number of cancellations possible, and we have schedules as full as they can reasonably be. Other big work that we're doing is we're focused right now on asking our we have a lot of doctors who have administrative tasks. So I'm unfortunately 100% administrative right now, no ER doctor, but we have a lot of doctors that are, let's say, 70% clinical, maybe doing 30% administrative. We're bringing more of those doctors back to the bedside and consolidating some of that administrative work. That will also get more people care. So more of our doctors doing bedside work and a little less doing the administration. So as I've said, that really is driving a goal of to see more patients per year, more patients per week, see patients sooner, and ultimately by driving productivity there, help us drive cost out of the system. That won't be enough for our challenges. So we have stood up what's called a sustainability council. So to give you a little more background, so the UVM Medical Center, we lost $13 million in February. We lost $15 million in February, and we're probably going to lose $14 million in March. We've lost about $48 million in under just about the first quarter here. It's not quite done yet. It's not surprising to me because more than $200 million of revenue came out in a day. But it is more than we can sustain at this pace, and it's driving urgency to make changes quicker than we might do otherwise. So the Sustainability Council is coming together with a target of taking $100 million of expense out between now and October. And they're at the network level. They're very focused on work that we can do quickly, focused on productivity in the hospitals, focused on some of the things we already talked about, focused on how we spend our money, how we use our money, how we work as a system, and they're giving back weekly updates. On top of what we're actually seeing right now, about average of 14 million a month of losses, the second part of the liaison consult report, also by A&M, looks at revenue over the next 4 years between now and 2030. And that report projects that we could have as much as another $300 million come out. So that really puts pressure on now to get things under control as best we can before more hits. And the way I'm talking about this at the medical center quite a bit is the revenue that we are able to bring in 2026 is less than the revenue that we brought in 2024. But all of our expenses haven't gotten less than 24. And from our budget guidance, the revenue that we're going to be allowed to bring in 27 is less than 26. So that's our problem in a nutshell. Usually the solution to these problems is revenue. It's not going to be our solution. It has to be expense reduction. And how do we do expense reduction? Preserving services as much as we possibly can. So I told you our losses, at the medical center, we burned through about 20 days cash on hand since October. In October, we had 148 days cash on hand for UVM Medical Center. Today, as we speak, we have 128. And the system has also dropped a bit to 137. If you want in a simpler view, the medical center right now is spending $460,000 a day more than we're taking in every day. So the changes that we are dealing with were good for Vermonters. It wasn't enough. We know that. We know there's more to come. But our expenses have to come down to meet that. It's challenging. It's hard. It's hard to take out expenses as fast as revenue comes out and not break things. And our goal is not to break things. So we are fortunate that we do have some savings to deal with that, but it's not forever. And at certain levels, we could do harm to ourselves. So we are taking appropriate urgency to make corrections right now. I want you to know that we understand that this is not enough and we have to do more. That our what we call our input costs, labor, supplies, and equipment continue to rise. Our insurance market in Vermont, it looks like it's a little better than last year, but still has big challenges. And we have to do our work to get expenses down. We're totally focused on that. But we're not going to let our expenses stop our critical work of delivering high quality care, improving our quality, making sure we deliver safe care, making sure that we're getting people seen. So it's a tight balance. We're trying to thread the needle here. We can't delay. I appreciate the opportunity to talk to you today. I've been talking about it a lot. So we had a town hall Thursday, medical center town hall today, and I've been out on the floors a lot, helping people understand our situation and where we're at. So I'll stop there. I'm happy to take questions.
Easy.
It's good to see you. Thanks for coming
Good to see you.
back, and thank you for all that you're doing. And I just am really hopeful when I hear about the positive changes taking place in UVM Health. Can you drill in a little bit to what's going on with our workforce? And you mentioned getting right. I think you said getting the right people in the right places.
Yeah, so there's a couple different levels there. There's at the bedside, we have to make sure that we're getting good productivity out of everyone that we have. And really what that means is using the tools that we have and invested in, like Epic, and using smart tools built in with that, and using data that we have to make sure that we have the right number of nurses on the floor for every shift. Not too many. That's a problem for expenses. Definitely not too few. We do have safe staffing collaboratives with our nurses, so we have guardrails to stay within. So in the hospital, I would say there's front end function. That's team that's taking care of you, your doctor, your nurse, your PA, maybe the person that comes draw your labs. There's all kinds of data we have for productivity there. Each hospital in UVM Health is focused on that work and getting that really right. And there is some opportunity there without question. That's a little harder because it's variable all the time. Like how many nurses do you really need on one of our floors tonight if you don't know how many people come upstairs from the ER? But we have, some pretty good predictive analytics for that. And there's back-end function, all the stuff that happens behind the scenes that in general, every hospital has a certain amount of that. And by using the power of the system, which we haven't done as well as we could to this point, but we're going to now, can you have a smaller HR team, a smaller IT team, a smaller finance team, a smaller quality team that's doing the exact right, so there's no duplication. So driving duplication out is an opportunity for us that the network hasn't, in fits and starts, we've gotten close a couple times, but there's no choice now but to push forward. Does that answer your question?
Yeah, very much. And I know those are hard decisions, so I commend you for doing those.
Thank you.
Go ahead, Lori.
The projected losses through 2030 include the projected losses from the provider tax and all the federal changes.
So I haven't seen the final report yet. Mike gave me a preview.
Okay.
And so I think they factored in, I hope they factored in everything, but I actually haven't read it yet.
Okay.
Go ahead, Leslie.
Thank you. Amazing amount of work. How does, if you're a research hospital, so how does all this affect the research that's going on? Because many of your clinicians are also doing research. How does that intersect? What's being lost, what's being gained? That kind of idea.
So we have, I'm going to make it simple. It's not quite this simple, but we really have three different types of doctors. We have people that are almost all clinical. They come, they take great care of people. Their job is mostly to be clinical. They are teaching medical students and stuff. So they're academic providers, but most of their time is at the bedside and maybe a small amount teaching, but mostly bedside. Then we have people that are researchers, and our researchers that are doing the highest level of research oftentimes get some support from industry, sometimes from the federal government. There's less of that now. And so those dollars offset their clinical salaries.
Losses, the clinical losses.
The clinical losses. And so there's a balance there. So, and I've heard people say, well, if you had less research, you'd have more people at the bedside. That is true, but they are also advancing care and part of our academic mission and part of how we attract really, really high quality people. And then, so most of our researchers that are at the highest level, that are working maybe 50% clinical, maybe 40% clinical, they have dollars to offset their salary. So they're getting paid just for the clinical they're doing. Then we have this third bucket that's administratives. So you might, let's imagine you're the chair of surgery or the chair of medicine, or you're the vice chair of quality for anesthesia. They all have some amount of salary that's not being a doctor, that's managing some program. And we have a fair amount of that. It's very common in academic medicine. And we can't stop all of it. It's part of how we deliver good care. It's part of how we drive quality outcomes. It's part of how we work on CMS 5 stars and everything else. But we're going to do a little less of it, is really what I would tell you. And so there is huge pressure on medical research right now from the federal government and how it's funded and how the dollars come through. That isn't a major focus of what we're doing here. We're being a little more targeted.
That's another question, another topic. When your predecessor was here a year or so ago, I don't remember when, the topic of bonuses came up. I'm wondering if you could talk about that.
Yeah, there are no bonuses in 26. I could talk more if you want, but that's probably.
I want you to talk more. Go ahead. I think you have more to say.
Yeah, so there is some data that putting some dollars for incentive for people at the highest levels can impact performance on certain things. And there's all these different things about what's your total salary, what's your base salary. And very often at the highest levels of leadership, the total salary includes some dollars at risk. You can call it bonus, you can call it incentive. There's some dollars you don't get automatically. You have to deliver on something like fixing a $200 million hole. That's not happening, by the way. I'm not getting a bonus for that. But you could imagine, but you could imagine that you could, the board could say, look, Steve, you took over, you're in a financial hole. We want you to be thinking about this every day. Believe me, I'm thinking about it every day. But so there's a balance, right? And so I think a lot of times people worry about the incentive, but if you think about it in the big picture of the total dollars that are paid, it's one way to drive behavior you want. And the Green Mountain Care Board has said a number of times that they would support incentive if it aligned with their goals. And I actually think that's a good conversation to have. And I think we should have it, but we're not in a financial position right now to be giving incentive. So there's no incentive for 26. So I think there's a huge conversation we could have about that. It's not an issue for this year.
So if I may, the argument was made that the medical center would not attract quality people without that kind of structure. Do you find that to be true or not necessarily?
We haven't been hiring a lot recently. We're in a little different situation right now. I can tell you that over my career that I've been really fortunate to bring in high quality people. I've hired people that were at the medical center and promoted them. And I've hired amazing outside people that came to Vermont. In general, to pull outside people to Vermont, they require more money. That's the truth. If you look at right now, our leadership compensation is at under the 25th percentile. I'm not saying that those leaders are not making a lot of money. I'm telling you, every one of those leaders, if they wanted to make more, could be somewhere else. That's not an argument for it or against it. That's the reality. People are here for all kinds of good reasons. We are able to bring people to Vermont right now that we need to, but we haven't been doing much of that.
But you're keeping people.
We are keeping people right now. I just saw, this is not actually what you're asking, but I'm going to brag about this because it makes me happy.
Why not?
Our retention for our nurses, or overall retention for 26 right now, actually all the way from first quarter, so last October, we're losing less than 5% of our workforce right now. So compared to the pandemic, shockingly better. But now people are worried. I've warned people that, we have a huge financial hole. We have to make some tough decisions. Everyone's work's going to get, if not harder, a little more stressful. And that will have a little impact.
So I come from the southern part of the state and we just had a potential strike of nurses. And of course you have the union contract. How is that working out?
One of our giant challenges right now is we have expense caps, and all of our labor contracts essentially are higher than the expense caps that we have. And to live in that world, that means if those contracts, we're going to live up to those contracts, which we are completely going to live up to those contracts, the money has to come from somewhere else. More than 65% or so of our total expense is labor. And our people in general deserve to get cost of living raises, and every single person in our union deserves the contract that we agreed to honor with them. So it doesn't leave many places to take dollars out. So we have a huge negotiation starting think tomorrow night with our support staff and our techs, about 3,000 of our employees. I don't believe we'll get to a contract that could live within the expense cap that we have.
So then what happens?
Has to come from nothing else.
Or you talk to the Green Care Board and negotiate that or something. I mean, is that, where's the room, I guess?
I think we're gonna find out.
Okay. I'll let you know. Yeah.
Any other questions? I wanted to ask you, so we have a couple Senate bills that are on our wall. Particularly, there's S-190, which we haven't taken up yet, but within that, there is sort of like, I'm considering it to be a baby step in reference-based pricing. And I'm wondering what your thoughts were, because that would have an effect.
Yeah, so Voss has done great work on this and we're fully aligned with Voss's position. What I would say my concern is that if you look at the Act 55, I was here last May talking to most of you. And when I came and spoke to you, I think we thought it was gonna have a $60 million impact. And then by August, we thought it was gonna be a $90 million impact. And then when we finished the budget, we thought it was gonna be a $100 million impact. And now we think it's gonna be 115, 116. And I don't think we still know. I would not be surprised if I come back, maybe not toward the end of the session, and visit you next year and say, you know what, here's what we really know now. So I don't think we actually know the full impact of these changes for a year or two. And so my big concern is I think there could be unintended consequences in either direction. I really wish it would be on the hospital side, but probably not. So we have a significant deficit to overcome right now. If everything in that bill fits within the budget guidance that we have and it doesn't have any leakage, we'll deal with that. That's our job. If it's more than that, it just adds to our challenges, but we will do what's necessary.
Did you say that you were committed to reducing revenue another 100 million next year or expenses? I didn't catch whether
Yes.
that was revenue or
Yeah.
expenses.
So for 2026, we built our final budget when all was said and done. Act 55, our budget orders, our commercial rate agreements with Blue Cross. We thought that was going to be 200 million. It looks more to me like it's 230 to 240 million now of revenue that's come off the medical center's books for 26. Okay, so 240 million of revenue, and we have to get at least that much expense out. Okay, in 27, if you look at the budget guidance that just came out, and this is still up in the air because we're negotiating with Blue Cross right now for what the 27 contract would look like, and utilization. Now we're going to get really in the weeds, but how much utilization they project for their premiums really matters. Getting that close to right makes a difference. We project that the agreement there to live within our budget orders for 27 could be another 100 million of revenue. We don't know yet for sure, but we're trying to build a budget that looks like potentially another $100 million of revenue could come out. So that would be another 100 million of expense reduction that we'd have to do to not be losing money. Does that make sense?
Yes, that makes sense. Which kind of leads to a question. Traditionally, the Green Mountain Care Board rather than regulating prices, costs, they've regulated revenue, which we hear from all the hospitals. It's this constant, well, our utilization was up and now we have to. What Green Mountain Care Board just completely switched their budget guidance, which, you know what? Dr. Leffler, you do as many services as you need to do, but you just can't charge more than this for them. Would that be advantageous? Would that be, or I shouldn't say would it be preferable? It just seems like this constant balancing of, trying to stay underneath the cap when there are pressures that put you over the cap, which then lead to reduced services that you can reduce.
Yeah, so here's what I'll say. Ultimately, Vermont has to figure out how to deliver more care at lower expense. However, we decide to do this, and I want to be totally fair to the Green Mountain Care Board because this is what they would say to you on this. And this is an ER doctor's version of the budget. If my CFO is here, he hates when I do this. I tell you guys all now, he really does not like how I talk about the budget. But here's how an ER doctor thinks about the budget. So looking at 27, we have to figure out how much it's going to cost to deliver all the care we think that people need are going to come to us. Okay. We come up with a number for all the care we think we're going to deliver. ER, ORs, ICUs, NICUs, we come up with a whole amount. And then for a long time, for most of my career, how we built the budget, we said, okay, we need this much money to cover our expenses. This is how much we're getting from Vermont Medicaid. We don't negotiate that. It's a set number. Boom, that plugs into one chunk. This is how much we're getting from Medicare. There's usually a little increase there. Can't negotiate that either. That's how much you're getting. And so for most of my career, we did the cost shift to Blue Cross. We figured out all the rest of it came from Blue Cross. And that's how we built our budget. And I'm telling you, he would be really mad, but I'm telling you about how we built the budget essentially. Okay. And there's a cost shift, and it still happens that way in most states. Vermont has so few people on commercial insurance that the cost shift doesn't work anymore. We've broken it.
Yeah.
Okay. That's true. So when we underestimated the number of people coming in from Medicare who needed more care, it should have made our commercial rate lower, but it gets mixed up in the out. So Owen would say, well, they got too much from Medicare. You should give it back to commercial. There is some version of that's I can't disagree with. The trick is there was some that care cost something. Okay. So there's a problem with that way. But the flip side is that there are more people seeking care. There are more people who need care. More people who don't have insurance need care. More people who have Medicaid need care. We are seeing more people who have Medicare, and the cost of that care that we're delivering is going up. So I do believe there's somewhere where should be allowed to see more people who need it. That's the doctor in me. I want to take care of everybody who needs it. I want to have as many beds open as I can. And then we have some mechanism where if we missed up a little bit in our budget, not because we were trying to deceive anybody, but we got the numbers a little wrong, that maybe Blue Cross gets some of it back, but not all of it back. That's value. That's a value contract. You hear us talk about it every single time we come. Getting that right is a little tricky. We're working on it hard right now, Blue Cross and the medical center. The trick around that is you have to believe, both sides have to believe the utilization. How much care are Blue Cross people really going to need? And what's the give on both sides of that? So that's a really complicated answer that any model you pick, if it makes care more expensive for people in Blue Cross, it's going to be a problem for Vermont.
Do we understand that cost of care? You talk about the emergency department. Do we know how exactly, like every single service line, do we know this is how much it costs us to have that emergency department staffed 24/7 at the levels that we need to be staffed for?
I can tell you that at UVM Health for our hospitals, we have pretty darn good numbers, pretty close. So I can tell you what it costs us to run our ED for an hour. I can tell you what it costs to run an ICU. I can't right now, but I could show you what it costs to run the NICU for a day. And we do know what our total cost per day is for having an inpatient bed. I think that some of the smaller hospitals in Vermont probably don't have quite as good of information as we do, but they have to submit cost data. So they have ballpark understanding of that. And some of our work is we have to make that cost a little cheaper. I mean, that is the work we're doing right now. We have to drive down the cost in each of those settings.
I just also wanted to ask you, because I know that your revenue has been below expectations for January, February, March. Of course, we know it's the beginning of the year, the high deductibles, all of that. Wondering how much of that loss is. We know that as the cost of care increases, that people are utilizing higher deductible plans, and if there's been any analysis whether or not your reductions are driven by that.
We won't know it actually till the end of the year, because you have to look at there's groups of people that their situation has changed, right? So we have people that were able to afford the exchange last year with a subsidy that don't have it now. And let's be honest, most of them are going to avoid care at all costs unless they have a catastrophic problem and show up in our ED super sick. Terrible. But there is that group that just doesn't have insurance right now. And I'm sure they're doing their best to not seek care, which is terrible. I hate that. Then there's people that were on the exchange and they had one deductible and they had to drop down and have a much bigger deductible. I heard people have it like a $10,000 deductible or something. I'm guessing all those people are trying to avoid care too and hope for the best. And so we are seeing our commercial utilization is down significantly. So about $35 million under in the first 2 months. We don't know what's going to happen yet. It's possible that some of those people will need to get some care. They'll figure out what to do with the deductible and then start using care. I think some of them will try to get through this year and kind of use their insurance as catastrophic only.
So it's that the commercial utilization has been down? Or?
So we budgeted relatively well what we were going to get,
Yeah.
but the utilization in the first 3 months is down significantly.
Oh, wow. Yeah, that's not revenue down. That's people are just not getting the care that they were getting.
It's both, but yes,
Okay.
yeah.
Wow. Any other questions for Dr. Loeffler? Yes.
When was the last time you've seen you put down? No, just curious. COVID.
COVID.
That was the last.
So COVID, two things happened. COVID, people didn't want to come to the hospital.
Right.
And we stopped basically a huge amount of outpatient services. So we stopped doing, I don't call it elective surgery, I call it no one chooses to get surgery. We stopped doing scheduled surgery. And we stopped doing a wide variety of things so people couldn't get care. And we basically just operated as an emergency type situation. So our numbers for commercial insurance plummeted through all of COVID. And then in 23, they came roaring back, right? And more than we expected by a lot. I think that's the only time in my entire career I've ever seen utilization go down at UVM Medical Center.
And since 2023, it hasn't until now.
So we have 3 months of data now that shows our utilization is down. I'm hearing from my colleagues across the state similar results. I don't want to speak for them. Devin might be able to, but my understanding is it's not only us.
Are you full? What's your census been?
So full census for us right now is 412 and we're 412 every single day. So we're full. But scheduled stuff is lower.
All right.
Excuse me.
Any other questions? Well, thanks for joining us
Thank you so much for having me.
for the rosy outlook. Really appreciate it. Thank you for your progress.
We're gonna get through it.
Thank you for thank you for your hard work.
It's time off as well.
I think it's time.
Okay.
Yeah, thank you for asking.
I will say, and I'll say this on record, when Leslie asked how much your bonus was, I'm like, if you said zero, is that zero after tax? Or before tax? Sorry, it's
Yes.
a little quick.
Again, thank